Okay, good morning, everybody. This is Lisa Schilling. Just a housekeeping item. I am not able to see participants, and I'm getting rid of the thumbnail of anyone's beautiful face or name. Patrick and I are monitoring the chat, so you're welcome to use that. And our goal is to leave at least 10 minutes at the end so that we can have a conversation, because we're really interested in talking to you all. But yeah, welcome to day 2 of COPRH, and this session is Building the Tower of Babel, Tricks and Traps in Harmonizing EHR Data. And I am presenting this along with my colleague, Patrick Hosokawa, and I will let him do a more formal introduction of himself when I turn the presentation over to him. I'm Lisa Schilling. I'm a general internist, health services researcher, and informatician, professor of medicine at the University of Colorado. And I'm going to start our talk today. So our learning objectives for you all today is to understand the challenges of using EHR data from multiple sites and understand some of the precautions to take when using multi-site EHR data for research. So just one of the things that I wanted to start with is, really, why is this important? Why do we do this? And Dr. Vach, if you were able to attend his opening session this morning, gave some great examples of using secondary data for research and the value in using this data, particularly to begin to do pragmatic research, right, as a real benefit of using secondary data. But there is a very large landscape of data research networks, and some of them that I just wanted to point out, and many that you've probably heard of already. But there's the Odyssey Network, so that's Observational Health Data Science and Informatics, and that is an international network. Many of us are familiar with the All of Us program, an NIH-sponsored program to capture both genomic and EHR data for over 1 million patients. And both of these use Odyssey, and All of Us use the OMOP common data model. So that is one of the mechanisms of kind of one of the standards for really harmonizing electronic data and other data like patient reported data and claims data. Sentinel Network comes out of Harvard and the FDA, and has really done a lot of work to monitor the safety of drugs and biologics and devices across the US. Oops, sorry, I didn't mean to do that. The VDW model, which is part of what some may be familiar with as HCSR, which is the Healthcare System Research Network, another very large distributed network. Then I think we're all familiar with the CoreNet, patient-centered outcome research, and that also uses the VDW as its base, but has really now has the CoreNet Common Data Network. And then there's Trinetics, and then a lot of this work really allowed us to spin up very quickly this national COVID cohort collaboration, or N3C, which also uses the OMOP Common Data Model. So all of these uses require a great deal of data transformation. And why do we want to use secondary data, and why do we want to go through this process of data transformation? I've got some animation here. Now I hope that it works. So one of the things is we can really capture a lot of patients. So this table, and I'm sorry that it's not in focus, but the meat of it is this is a project that we are doing with University of California sites, and then also the VA, Emory, and some additional sites, to really bring together another COVID collaboration. And we've got over 55 million patients, over 3 million that have been tested, and 80,000 patients that have been hospitalized for COVID. So one is there's a lot of patients and a lot of data that we can get by working within clinical research networks. And why do we want a lot of data, right? Well, we want a lot of data because some diseases are rare, or their outcomes or adverse events are rare. And this is work that came out of Germany with a distributed research network, really looking for similarity among patient kind of pathways in EHR data to identify potentially, rare or undiagnosed disorders. Another value of this distributed research network is really to be able to capture kind of comorbidities on so many of the patients that you might want to study, right? And this study used actually not so much comorbidities, but they were looking for symptoms and diagnoses before a patient had an ultimate diagnosis of cancer. So what are some of the things that we could do to maybe identify cancer diagnoses earlier? No. This is the Odyssey Network, just a quick kind of overview of kind of the national representation. So what you can see here is that you really begin to be able to study disease across geographies. And we know that treatments occur temporally in different areas and geographies. There are different environmental situations, there are different policies, and all of those can be studied when we can create, networks such as these. So, and this is one study that came out of the Odyssey Network, actually looking at the use of hydroxychloroquine for COVID and what was going on that time as far as what were the policies and what was being published. And you can see how rates went down geographically. Other real benefits of having kind of all of this data is really the availability to identify negative controls, and Dr. Bach spoke about some of the issues with patient matching. So the more patients you have and the more information you have about those patients, the better you can match for observational studies or pragmatic studies. The other thing is that, as we make the data kind of more standardized, we can actually focus on the science of generating discoveries and evidence out of that data. So we can really democratize the data, right? It shouldn't be the data that's a barrier to people having great hypotheses and being able to test those hypotheses. And in the past, it has been a little bit that if people had the data, they kept it to themselves, and they were the only ones that were really using that data. So just to give an idea, when we talk about common data models and common vocabularies as a way to really harmonize information, what are we talking about? This is a visual of the OMOP common data model. And I'm not going to go into this in detail, but if we start at the left, this is what's called the standardized clinical data. So you can see that it's person-centric and that we can store information about observations, about visits, about conditions or diagnoses, drugs, procedures, devices, measurements, which you can think of as similar to labs. So anything that you can measure and really get a number value or an absent present, notes, surveys, and other information. Also, if we look at the middle column, you can see there's information about the health system, right? Because we do want to know information about providers, sites of care. Some of the standardized derived elements have to do with derived variables that we may compute or create that have to do with things like how long a person had a certain condition, or how long they were on a certain drug, or how long they were on a dose of that drug. And then the last column really maintains the standardized vocabularies themselves. And because we not only need to have data formatted in the same kind of representational model, but we have to have the same semantic meaning about the data. So the table on the right that you see now, if you go down to kind of where, let's see, I'm going to try to put my cursor here on the concept code, this 494, that would be an internal code for a fib that is based on SNOMED. But what we don't know is that another site may actually store this concept of AFib completely differently. So this is where there has to be some harmonization about the codes that are within the systems and what they mean, and then actually translating that to a common code. And Odyssey actually uses their concept IDs to do this. And they have kind of terminal vocabularies that they use. And for the domain of condition, SNOMED is the terminal vocabulary. But within our EHR systems, there could be other terms, vocabularies that are used. So you can see that this harmonization includes both the semantic with matching to common vocabularies or ontologies, and then also the format that the data is stored in. So the other thing that's really essential when we think about any given site kind of harmonizing, standardizing their own data, either as part of a distributed research network or even doing it to submit it to a central kind of organizing body, is that you really have to understand the type of data you have. And so this visual is really something that's looking at source databases. And here, there's an allergy table and a care plan table, and really looking at the type of data that's in that table. So here we're seeing, what the data type is, what the length of characters for that data type, and the last column G, is whether that field is actually empty or has data in it, because that is key. And then if you look to the right, we've got an example of something that most of you would recognize. If we had our source database, and here, sex 2, is male or female, and 1 is probably the other. And then this list is truncated, but there would be other options here, and you can see what the frequency is. So this would begin to give us an idea of what we have, because you need to know what the source data is before you can decide how to transform it. And if you received something that you were expecting, like I really need to know, the patient to be able to link this information, or I really want dates, then we may need to go back to the people that are most familiar with our source data and ask them, do you have this information? This is what I'm looking for, and this is what I need. This is a visual that actually comes from Odyssey. They have a mapping tool that is a rabbit in a hat, and you can use this tool to actually begin to do your mapping and create documentation of your mapping. But as an example of what this takes, see on the source side, I have an ID, I have a birth date, and that ID is going to be mapped to my person source value within the OMOP Common Data Model. And that birth date is going to be mapped into a variety of fields, including the year of birth, the month of birth, the day of birth. And if we have the date time, then that may be also another field. And there may be some redundancy in those fields, but this is what you would want to know so that you could begin to do this mapping. And then something like sex, which is not here, we would, but was on the prior slide, we would need to be able to begin to translate that 1 and 2 into a concept that was going to be known across kind of our network and following the conventions that we've established. So where does this harmonization occur, and how are the conventions specified, communicated, how are they verified? And I mentioned a little bit before how you could have a centralized model. So PEDSnet, which is a PCORnet data network, actually has a centralized model where people send their data to the central coordinating body, and they kind of do the final ETL conversion. But obviously, the people submitting that source data need to kind of have an eye on how that data is going to be modeled, right? Because they have to make sure that they're getting the right data from their source to actually be able to submit it. Distributed model relies on everybody kind of transforming their data locally, and they would need to follow the outlined conventions that are specified and communicated. And this may be, written documentation. There may be data quality checks and reviews that are done. And Patrick's going to get into a little bit more about that and just how this is verified, because this is very important. The conventions, that they are clear and clearly communicated, is important, because they do need to be followed if we're going to rely upon the fact that the data is quote unquote harmonized, which means, when I want data field X, I know that I'm getting that same type of information from all of my sources. So one of the things that is key is the source data to target harmonization. And it's very important to have established data dictionaries and to work with partners on this. The formats for harmonization and standardization of given variables may be slightly different, and create processes that need to be kind of adjudicated. And there's often kind of a number of rounds in going through this process. And really, I think this process works best when we have both data experts, source data experts, common data model experts, that they really need to work together to design the ETL, to understand kind of the semantics and the meaning of the information and which source information is kind of the best to begin with. I think you really need people that have medical knowledge. This doesn't mean that they necessarily have to be, a nurse, doctor, or other kind of healthcare provider. There are many of us, who have been working in the field of healthcare research for many years that do not have those degrees, but really have learned this over time. And so that is key, that someone has that medical knowledge, ETL expertise, and then really a system of kind of quality control and continuous improvement. I feel like part of the harmonization processes, you can get to maybe, 70–80% of what most people are going to need for research. But when it comes to really refining things, there's nothing better than using the data, making sure that the users are performing some sort of quality control on some of the key data elements that they are using, and actually using that to further inform and really turn the crank on your entire process, so that you can be assured that the data is of high quality and represents kind of what people think it represents. So let's see. I'm just going to go one ahead here.
Your ETL
Patrick,
slide is 14, I think.
Yeah,
if you want to go to
okay.
that. Sorry, I put those in beforehand. I thought I was going to take over on slide 9, so I got messed up on the transition.
Well, I can, no, why don't I have you take over here? Yeah, that threw me off. Sorry, folks. And I will have you take over right here. And why don't I'm going to pass it on to Patrick. And Patrick, remember to do your introduction, and I'll have you take over from the ETL dictionary. So this is great.
Okay. Great. Yeah, my name is Patrick Hosokawa. I'm a statistician, data analyst. I've worked a lot with the ETL process, kind of where the rubber hits the road of actually sending out these documents and negotiating back and forth with the partners on the actual data. So we can see here, we have several projects we could choose from. This is one of the current invested project, is the data we sent out to them for a particular table. This one here is sort of a visit record. So you can see we want the date of service, we want the visit type. Now this comes into one of the things that Lisa was talking about, in that a visit type frequently will differ from clinic to clinic. They'll all have different names. Some will call it in person, in office, face to face. There's lots of different names, and we need to both harmonize those with each other and then get them down to a reasonably small set so that future folks can work with it. So frequently the back and forth will go, actually, can you go down? Let's see. Looking for the one with the variables on it. Let's see. Actually, doesn't look like we have it here. Basically, the idea with the visit type, like I said, we can get it down into several small sections. Now, OMOP goes past that. In many projects, you'll deal with a local list of values. The problem is that with OMOP, each person doing a project will come up with their own list of values. So if you want to combine up to a larger level, you need those to be consistent. So what OMOP does is it puts out a set list of visit types, basically trying to cover everything you might have locally, and then puts those into standardized code so that a face-to-face visit is visit type 2, and that's true of any OMOP database, which helps keep these things much more harmonized. Provider type is similar, Primary insurance frequently will be a set value. It's very difficult to combine those unless you're looking to take individual insurance types and aggregate them into private, government, VA, Medicare, that sort of thing. It's not uncommon. We had seen this in one of the diagrams Lisa showed earlier, to go ahead and aggregate it and keep the source value in the table for later. This can be very useful in letting the analysts re-aggregate the values. It has been common that we've seen people come back to us go, I don't want this processed value. Can you give me access to the raw data? Go ahead and go down one. So again, this is a medication. Now, this is an example of one example where people can get messed up on the nature of a field. For instance, date of data pull. What this means is it wants to know the actual date you got the data, not the date the medicine was prescribed, not the date it was collected, not the last date that prescription was checked, but rather the date you pulled it, so that we can say everything in this table is current as of this date. Now, that took a couple of rounds with different patients, and it took actual quality control to look at that date as it came in and say, is this likely the date of data pull? Are they sending us something else? That sort of thing. Frequently, if you saw the date of data pull and the start date of medication being the same, that would be an example of sort of a interpretation disagreement. NDC, fairly straightforward code. Again, you have to look at that one to see what you're getting in there. There's another quality control. People may send you GPIs. People may send you some local code. You got to check it to make sure you are in fact getting NDCs. Could you go down to the next slide? I want to make sure I leave time for questions here. Okay. This again, let's see. I think we've covered most on here. This one also has some notes in where you can see the kind of patients you're not supposed to send. Comments on when you should be including these, and these can get very involved and frequently require back and forth with the facilities. Go ahead and go down one more. I want to keep moving on these. So some of the challenges we faced in projects before. The categorical values will have distinct local values and variants. Again, that's a matter of standardizing those values, and it can be very important to take your aggregations and bring them back to the partner, because it can be common that we've misinterpreted what their local value is, and in particular in the cases where we don't keep the source value, if we aggregate it, that information is lost from that point forward. Format for a single variable differs between data sources. Frequently, you'll get a string, say primary insurance, in different sizes. If you're not careful when you combine the things, you can get truncations on your longer ones that don't often show. Numeric values contain character notes. This is probably the biggest single time sink we see with some of these. Yes, for a numeric value, say albumin, you'll get values like 1.2, 1.5, but you'll also get values like didn't test today, NA, less than 2, greater than 5, range 3 to 5. Those will come through as characters. If you're not careful about how you read that in, they'll basically just come through most processes as null. And if you don't have warnings up, you may never know. You'll just have null values because they put that stuff in there. Numeric values can differ in units. Height and weight are the most common. You may get weight in kilograms. You may get it in many different, formats. One of the most common ways, and this is crucial to overall quality control, is to frequently run these values by facility. And if somebody's sending you weight in kilograms and everyone else is pounds, that's going to show up right away in any kind of profile between them. A couple last sections, variable sets. And we saw this, oh, I'm sorry, it was on the last one, whatever slide you were just showing. Variable sets, for instance, diagnoses 1 through 20. It's common you'll get those in columns 1 through 20. It's also common you'll get them in rows, 20 rows per visit, diagnosis in each row. Frequently asking them to transpose that is beyond either the resources or the capabilities of many clinics. So it hasn't been uncommon for us to go ahead and transpose those for them. One lesson you learn in this is you have to work with different facilities according to their own IT abilities and according to the time they're able to spend. And so it's not uncommon to have to kind of meet them more than halfway on some of these things in order to maintain relationships with a lot of the clinics. One of the ones we did for Safety Net that Lisa and I did a long time ago, tried to get around that with an automated toolkit sent to the partner. And it's sort of beyond the scope of this to try to go into the various trials and tribulations with that, but it was tricky. So, like I said, automating this process can be very tricky frequently. Is there anything on the last slide? I think we're at 26.5 minutes, so we probably want to shift over. Lisa, is there anything you think I should have commented on before we go to questions on sort of the rubber hits the road part?
Well, I did move one of the slides before you were ready, and there was one great comment in there about how sometimes PHI slips through. And we have seen that in a number of cases, and Patrick had a comment to check early and often. So
yes, we had recently, I'll just comment real quick, PHI that came through on hidden columns on an Excel spreadsheet. And it actually took a bit to find that because I didn't notice that the worksheet started at D and there was these hidden columns off to the side.
Yeah,
you got to be careful with that.
Yeah, we find that sometimes when we're taking like Epic, for example, when folks are using Epic flow sheets and there may be a comment kind of bar in the flow sheet, right? And someone will put PHI like Mr. Smith doesn't really want this today or something like, like that. And so, and it gets sent over, with the rest of the flow sheet that is completely not PHI, may just even be a bunch of numbers, responses to questions. So, but yeah, we'd really like to open it up for, discussion and questions and hear about other folks' experience. So please feel free to unmute yourself. If you prefer to use the chat, that's fine too. We're looking at that. So.
No question.
This is Mike from Learning Times. Just real quick, participants are free to go ahead and unmute. If you'd like to ask any questions verbally instead of typing, you can go ahead, unmute, and when you're done speaking, unmute, just mute yourself back, please.
No questions. No.
Experiences. I'm really kind of curious kind of what other experiences people have had, either doing work in distributed networks or doing or trying to centralize kind of a data harmonization.
Right, particularly if anybody's tried to automate it at all. Like I said, that can be tricky. Well, oh, here we go.
So Katie Seidler currently creating an ETL process and talking about how not to have PHI sneak through. The last point was validating.
Yes, frequently you have to just look at the data. Automation is the enemy of that because like Lisa said, it can sneak through in comment fields. It doesn't necessarily mean the name is filled in or anything like that.
Mm-hmm. I'll just share, we're doing some work right now validating a phenotype for persons who were admitted to the hospital with COVID-19. And we were using in our phenotype specification, we were using some of the criteria that the CDC had around using the diagnosis codes. So, after April 1st, diagnosis code for COVID itself became available. So before that, it wasn't available. And this is just, kind of understanding that the source of data and how you've harmonized it. But the diagnoses for a hospital course are actually tied to the admission date and not the discharge date. And we originally created our phenotype. We were thinking, oh, it's the date they get discharged that they get their discharge diagnoses. And therefore, we created our phenotype, with our April 1st cutoff for different codes based on the discharge date. And we went back and did validation. We realized they're all linked to the admission date in our EHR. And I think that's pretty standard for other EHRs, but that's kind of an example of really kind of having someone on your team who really knows the source data if you're trying to kind of harmonize and translate a whole kind of database. And at our university, we go from our Epic caboodle, as far as clinical data, we go from an Epic caboodle into the OMOP common data model. One of the other slides that I had was that Patrick spoke to was the data dictionary for our enterprise clinical data warehouse. And so it's, if your site has one of those that really outlines kind of what their data means, and that's very helpful in the transformation process. But another example there, and please interrupt me because we'd rather hear from all of you, but I am going to take the time to just share a few experiences if we have it. But is that we take death from two different sources. We have death in our electronic medical record, so that will be documented if someone dies in the hospital under our care, or if we learn kind of from a phone call from a family or other proxy that a person has died, or we enter that into the electronic medical record. But we also combine our data in our enterprise data warehouse with the state death registry. And so we have dates of death that come from that registry. And the one thing that our data dictionary kind of outlines is that the death date is taken first from the state registry, and if not available from the state registry, then takes it from Epic. So we've made kind of a decision that the state registry is the more kind of definitive or authoritative source of death data. But those types of decisions are kind of made all along, and you need to be aware of those if you are a user of data, right? And you really want to know kind of what the source is, but also if you're someone who's responsible for data harmonization in ETL. So.
Hi, this is Kathleen, and Kathleen Albers from Kaiser Permanente, Colorado. I just wanted to draw attention to the fact that sometimes we have biases entering on how we expect data to be collected, even within the same enterprise. For instance, coming from Northern California, we thought medical record number, you have one, that is your number for all of time. And working with KPCO, realized that you can have multiple MRNs over the course of time. And so even though something as simple as MRN you would expect to be the same across sites and building code across that, every variable you need to go through with each site to understand it. For instance, sometimes at sites, if you're not the subscriber ID, you might just have your birth date imputed to be the day of one instead of the actual day of your birth. And so when you're trying to match back records, you could have a mismatch. So it's good to just go through every variable, not just the more complex one about how claims are processed or how to find specialty departments, but every single variable. Thank you.
Yeah, that is such a great comment, and it does kind of it brings up the whole issue of boiling the ocean, right? Like when we do OMOP, we try to do like everything, right? And to go back and think about a distributed research network and having everyone validate every single field is tough. It's so important, and yet there's probably some limit. I always think about like, what are the key variables researchers are going to be using? And let's make sure that those are absolutely right. And obviously a person ID and MRN is such a key example. So we have 1 minute. Oh, good.
I was just gonna say it's common, to have to deal with those local IDs. You usually want to retranslate them because A, they might be PHI and you don't realize it, and B, they frequently duplicate across facilities. Not so much with MRN, but person ID, if you're not careful, you just read it in and put it together, you're going to get lots of duplicates.
Yeah. Well, we are at time, and I know there's more to follow. So on behalf of Patrick and myself, we want to thank you for attending this session. We hope you enjoy the rest of the day. And I think Mark Reitz is up. So thanks, everyone.
Cool. Great. Thanks.